prescribing update. Sorry to those of you that were hoping for an in-person session, but it was difficult to get it together in the end. We've got, so I'm James Fordham, I'm a GP at the Nightingale practice in Clapton, and I'm also the GP representative on the CAMHS Alliance board. We've got 3 speakers for you today. The first is Brenda Ong, who is a senior community mental health pharmacist. She's going to update on some of the key areas in adult prescribing in the first hour of the session. And then we're going to focus on CAMHS prescribing issues in the second hour. Kirsten Mitchell is presenting on SSRI prescription in children and young people. She's one of the consultant psychiatrists in the paediatric liaison team. And then Kate Manning is going to talk about ADHD prescribing in children and young people, as well as the melatonin prescription guidelines. Kate is the ADHD consultant and co-wrote the local melatonin guidelines. So now I'm going to hand over to Brenda.
Hi, good morning, good afternoon, everybody. So let me just start by sharing my presentation because that might be useful. So I'm hoping that everyone can see my presentation, and if not, just let me know. So I'll just start. So as James mentioned, I am one of the senior community mental health pharmacists. I've just started my role in April with the primary care liaison mental health service. A little bit of background about me was that I've worked for 6 years as a specialist mental health pharmacist, and yes, just kind of starting my new role with the primary care liaison team. So really the session today is just to give you guys a bit of update, as well as just maybe having a bit of a conversation about kind of any difficulties that you find in kind of mental health prescribing and what kind of support you might need as well as part of my and how we can access that support as well. And feel free to leave some questions and comments in the chat box, and I'm sure people will help me to kind of highlight that as well. So a brief overview is just about some of the changes in the health formulary and some potential updates in the guidelines for mental health, and just touching briefly on psychotropic physical health monitoring, also really talking about transfer of care between primary care and secondary mental health care, as well as supporting in managing medicines for those who are stable with mental health conditions, and also just kind of briefly going through primary care liaison medication referrals, just kind of commonly asked questions or things that have kind of come up since I've started my role, and then just a bit of time for Q&A at the end as well. As I mentioned earlier, it's meant to be more of like a conversation. I'm not really hoping to bore you with like a long lecture of things that you probably already know. So I'll just start with the formulary changes. So there's 2 new medicines that have been regraded in the health formulary. The first one is agomelatine, which is a melatonin receptor antagonist, and that's licensed for major depressive disorder. This was regraded from red to amber status, and it is remaining available as a treatment option for those who do not respond to generic SSRI treatment. With this medication, ideally, it is kind of, we normally say there is ongoing LFT monitoring, and we are in the process of making a submission to the City and Hackney CCG formulary. In terms of the amber status, that does mean that it is kind of still recommended for initiation in secondary care as compared to initiation in primary care, but it's just kind of a another option that's going to be available to patients as well. The second medication would be for is bupropion, which has also been regraded to amber status. At the moment, there's no license for treatment of depression in the UK. You might commonly know it for as an option for smoking cessation treatment. So it has been added to the health formulary for the following indications. I think the slides will be sent to you later as well, so I'm not really going to drone on about it too much as well. And I suppose it's mainly for a lot of patients who might have sexual dysfunction associated with SSRIs, and also for those that have like antidepressant-induced weight gain as well. And the prescribing really should only be undertaken in agreement with the service user's primary care physician with a clear plan. So really, if we're planning to initiate it in secondary care, there should be like a conversation with yourselves as kind of primary care clinicians in terms of responsibility for continuing that as well. And again, as Amber stated, it would be initiated by secondary care unless it's a patient that has already been established on treatment, which I'll go into a bit later on towards the end of the session as well. So in terms of upcoming reviews for formulary and guidelines, it's more of like a watch this space kind of area. One of the guidelines that is planning to be updated is about managing psychotropic-induced hyperprolactinemia. It was agreed within ELF that we would update this guideline to support our primary care colleagues in terms of managing psychotropic-induced hyperprolactin. And I guess it was just more for me to ask yourselves within this forum what might be useful in terms of if we're updating the guidelines, what would be useful for primary care clinicians to know about the escalation process, etc. as well. So would love to see your comments in the chat box, and I'll also send a feedback form out later on as well to see if you could add any comments as well. We're also in the process of reviewing the amber and red psychotropic medicines within the formulary. At the moment, there is no fixed plans on changing any of these at the moment, but we're just kind of doing a whole review on what psychotropic medicines are red and amber at the moment, and then we'll look at perhaps reviewing those over time as well. So that would include things like second generation depot antipsychotics like paliperidone and aripiprazole, as well as oral lurasidone as well as one of the antipsychotics as well. Any questions so far about that? Sorry.
Can I just ask Brenda? So were you saying that Zyban is an option that doesn't cause weight gain for patients?
Yeah, it's less likely to cause weight gain at this in comparison to other kind of for example, your typical mirtazapine. But we do know that in terms of the low mood and depression or anxiety type conditions, when someone's mood improves, they might tend to eat a bit better as well. So that can kind of be a different way of saying weight gain. It may not be a necessary direct side effect of the medication, but kind of like pharmacologically, we tend to see less weight gain associated with bupropion as well. But obviously it is kind of an off-license treatment, so we wouldn't be recommending that as first line necessarily.
Thank you for that. There's another question that's popped up from Jonathan Tomlinson in the questions. Does AMBER mean only to be initiated by secondary care, or can primary care initiate?
It should be initiated by secondary care and then kind of transferred on to primary care thereafter.
So there's no other questions in the chat box at the moment. But if other people want to ask questions, they can't talk out, I think they can either raise their hand or put a question in there.
Yeah, that's fine. All right. So the next bit is just about psychotropic physical health monitoring, which I'm sure that everyone's quite aware of. And in terms of why it's really important, as we know that the life expectancy for adults with psychosis or schizophrenia is generally between 15 to 20 years less than for those in the general population. And this just from the NICE guidelines that adults with psychosis or schizophrenia, it's recommended to have their health checked regularly, at least annually. These checks for problems such as weight gain, diabetes, etc., and should be shared, as jointly with secondary and primary care. What we normally use as a guide is the Leicester tool, and this is kind of from 2014. It hasn't really been updated yet or since, and we're still kind of using this as kind of our go-to in terms of monitoring physical health for those with psychosis and schizophrenia. This can just be searched quite easily, the Leicester Cardiometabolic Health Resource, but this is in the slides as well. And it gives a bit of guidance in terms of what we're looking for, and then also how frequently we need to do it as well. So just at baseline, weekly for the first 6 weeks, 12 weeks, and then annually. And that's probably, the annually is a bit more focused for yourselves as primary care clinicians as well. I think one of the things that I wanted to share or kind of note, I suppose, is that it is important to do this, but I can understand the difficulties with primary care clinicians in the fact that some patients with severe or mental illness can oftentimes not be very engaging with the practices, and just trying to figure out, maybe if I could know about in the chat box what kind of challenges you face in terms of trying to engage this client group in engaging with the physical health monitoring, or what kind of support you may need from ourselves, the secondary care team, to help with the physical health monitoring. Because I understand there's some templates that you use on EMIS, but I'm not sure in terms of how much detail that goes into in terms of the monitoring as well. So it'd be just useful to hear about your comments and experiences as well.
I think in our practice, this often gets done in annual reviews. So the way that it works with us is a nurse does the physical health check initially, and then we review them. And yeah, there's templates that are used to make sure that we cover all the appropriate points.
Yeah, that's perfect.
Do you want me to put forward some of the other questions in the Q&A, Brenda, or do you want to leave those till later?
I think it just says it would be helpful to have guidance on antidepressants and QT prolongation, as well as the baseline needs to be done by people initiating the medication, and ideally the 6 and 12 week as well. Yep, completely agree. And that should be done within the secondary care setting, and once that's been initiated. And I suppose depending on the setting that it's been initiated in, for example, if it's an inpatient and they've only been admitted for 2 months, that might not meet the 12-week kind of period as well. So just to be mindful of that as well. The next thing I would just wanted to touch briefly on, which I'm sure everyone is already aware, is just about valproate prescribing. And as we know that the use of valproate in pregnancy is contraindicated, and just kind of a larger focus for us is in terms of bipolar disorder, and that it must not be used in any woman or person of childbearing potential unless there's a pregnancy prevention program in place. I think just from my experience in inpatient setting, when we do come to do like medicines reconciliation, it's quite difficult sometimes to tease out whether someone is on highly effective contraception, for example, like a coil or like an implant, and including like a date for renewal. Probably just want to get some feedback from yourselves in terms of what the best way would be to identify that if it's not on the SCR. And I suppose some feedback that I've gotten from primary care colleagues is that it's very difficult to identify when an annual acknowledgement risk form has been done by a secondary service. And I suppose that's kind of where my role lies within the primary care liaison team. So at the end of the session, I'll probably provide you with our pharmacy email address. So if you have any concerns about that, please feel free to send an email if it's about a particular patient as well. And then in terms for primary care, just ensuring that the patient is referred back to the specialist for annual review, and then obviously referring to our teams as well in case of an unplanned pregnancy or where a patient plans to, wishes to plan a pregnancy as well. And then the last bit was just about lithium monitoring, which I think most individuals already know about the frequency of monitoring, but just as a reminder that, the ECG is recommended at baseline, and for high-risk patients or those with family history or comorbid cardiovascular disease, the renal function, thyroid function, and calcium levels should be done 6 monthly. And oftentimes from practice, I've noticed that calcium levels are not normally done, but this is just really to monitor parathyroid function. So it's really important that that's done as well. and serum lithium levels, ensuring that it's done 3 monthly, and ensuring that it's a trough level as well. That's 12 hours from the last dose of lithium as well. Any questions on that at the moment?
There are some general questions.
Yep.
Dr. Imran Hussain, I was under the impression that AMBA drugs can be initiated in primary care provided the prescriber is experienced with the medication.
I think I may need to just double check that, but I'll certainly get back to like yourself, James, maybe in terms of like collating questions and then just kind of getting back to you. But I'm sure it's initiation in secondary care, but I'll just double check that after the session as well.
Sure, thanks.
Yeah.
Mayuri, does ELF have a guide for GPs for the physical monitoring that MMT can share with GPs?
That medicines management tech team, yeah. I think there is some work that's being done in the pipelines. I need to liaise with one of my consultant colleagues, but certainly if that's something that needs to be explored, it can be developed working with primary care team as well. But I think the templates on EMIS do cover the physical health monitoring quite comprehensively already, if I'm not mistaken.
Did you say that you mentioned is it the Leicester cardiometabolic health resource?
Yeah.
So yeah, I hadn't heard of that. So we can look that up pretty easily.
Yeah.
Yeah. Okay. Thank you. Charlotte Morgan, why do we need to refer back if the patient had valproate started in secondary care? Should they not remain in follow-up?
I think there are some cases which I'm planning to kind of discuss within our wider team as well, as the community mental health team structure is changing, and the neighborhoods team structure is changing as well. Because I have seen in practice that there are some patients that are, although they're on valproate and there are childbearing potential, they do get discharged back to primary care. So it's something that I would want to raise, and as I mentioned, I've only recently started my role 2 months ago. So it's just something that I'll probably raise as part of our ongoing business and quality meetings as well. How do we capture these subset of patients as well, and how we would best follow them up as well. So I hope that answers the question. And I guess just in general as well, I know I kind of touched briefly about on occasion, it may be difficult to capture a small subset of patients who have severe mental illness in helping them with their physical health monitoring. So just I know Mayuri kind of mentioned about developing some guidance on physical health monitoring as well, but would love to hear like some comments and feedback as well on how else we can support yourselves better. Yeah. So this is not really relevant fully to prescribing, but I thought I'd just briefly touch on it. As you know, the neighborhoods teams is kind of like a work in progress at the moment, and I just wanted to show you this phase in terms of what we've actually been doing thus far. And I think historically, many people know about PCL and CAMHS, and over time, that's kind of evolved to our kind of neighborhoods mental health teams, where we kind of do the screening, we do outpatient assessments, and there's duty team as well, and then we're hoping that the complex needs team will sit kind of separately as part of our neighborhoods team. And kind of complex needs patients, that would mean patients who normally require like care coordination or kind of more intensive input from secondary services in your traditional kind of recovery CMHT package, I suppose. And just to make you aware that the clozapine clinic and the antipsychotic depot clinic won't be part of the neighborhood service. And so those patients under primary care that are on these particular medicines, they would still need to be contacted separately as well if there were any queries, I suppose. Within my remit at the moment, I'm kind of more towards the primary care aspect and supporting primary care in terms of providing prescribing options and also ad hoc consultations where maybe first or second line treatment hasn't worked for particular patients and they need to explore other medication options as well. So, happy to take on referrals as well, but to be mindful that I'm one pharmacist covering 7 PCNs. So there might be a bit of a waiting time, I suppose. And then I just briefly wanted to just talk about medicines reconciliation. Prior to this session, I did kind of do some scoping a little bit with our inpatient colleagues and also just some of our colleagues that work in primary care as well. Oops. And then one of the main feedback that we got from the inpatient team was that oftentimes there's lack of like hospital only medication that's documented on the summary care records, including clozapine or specific like HIV medication, as well as like some diagnoses that may not be matching to the medications, which oftentimes can lead to delays in obtaining treatment while they're in inpatient setting. So I guess that was just more feedback for yourselves as primary care clinicians, and I'm not too sure whether that's something that needs to be discussed wider. From the primary care aspect, I'm aware that there is ongoing delays in kind of discharge notification from mental health teams. Sometimes the discharge plans can be quite unclear as well in terms of how long a patient should be staying on medication for. Sometimes even the medication list is incomplete depending on which teams they have been discharged from. So I think what is always best is obviously to link in back with the inpatient wards and inpatient pharmacy teams. They're pretty responsive. And even as myself, as part of the liaison mental health service, I do have access to the inpatient records and inpatient drug charts as well. So, more than happy to provide that support if there's any issues with clarifying what's gone on in the inpatient setting as well. The other thing I wanted to highlight as well in terms of we have our neighborhoods daily referral meetings. So any profession within the primary care team is more than welcome to present like a case or seek advice from our team instead of sending a referral. And if you're not aware of what times those daily referral meetings occurs, can link in with the mental health SPA team, and they can probably give you some advice on when those are, and it's normally by teams as well. Any questions about that so far?
A couple of questions in there. Is there a single point of access for referrals to mental health services, or is it via ERS? Do you know about that, Brenda? Or is that...
I'm not too sure, but I can definitely find out. There is like I think the plan is to kind of merge this all into a single point of access service. There is a default email that referrals can be sent to my understanding, but I can definitely clarify that at the end of the session as well.
I mean, I cover CAMHS, but my understanding is that it is single point of access via ERS, and then it comes into the neighbourhood for the neighbourhood referral meeting to decide where it goes next. That's my understanding. Mayuri says, can we enable the chat function, please? I don't have that ability. I was wondering if we get to the end of the slides, if maybe that could be opened up at that stage, Alana, or even allow people to unmute themselves and to speak, because we haven't got a huge amount of participants. And one of the great things about if we had been meeting in person is we could have a much better discussion in the room, but maybe we can facilitate that somehow at the end of Brenda's slides.
Yeah, and I guess there's one from Charlotte, which I can see at the moment that it is quite a tricky time because it's the busiest time when the daily referral meetings are being held. And yeah, completely understand that it is really busy. But if you do have capacity, that's one way. And I'm more than happy to take direct referrals from GPs as well if it's regarding like an issue about medication. So I'll leave my email details at the end of the slides as well. So that, if it's something particular about medication, it doesn't necessarily have to go through the entire referral process, and just kind of making a bit more open access, I suppose.
Yeah, sorry, can I just make a point? Following on from what Charlotte said, the way that we do it at my practice, we give ourselves, a block to attend the meeting. But I have found it slightly disappointing at times that, for example, I've made a referral to the neighbourhood team and wanted it to be on a particular day when I'm in, and then it's ended up being scheduled for a day when I'm not in, and it just gets discussed without me, and the point of the referral has slightly been missed. And Yeah, so I think there can still be some work done on how useful the neighbourhood referrals meetings are.
Yeah, I can take that back as feedback as well to the team. So that's perfect. Thank you so much. So just moving on to the next slide. So I guess this is kind of a very common question that I've been getting asked as well, and what I've seen in practice. And a lot of the time we have about trying to increase confidence for primary care in terms of titrating psychotropic medicines. And I guess a lot of the times you can see about from clinic letters or notes that patient's mental health is stable, remain on same dose, and discharged to primary care. And what we normally do tend to see in practice is that lots of patients are left on the same doses of medication, which can sometimes we use to treat the acute period of illness, and they can be on this years after they've been discharged from service. And there's often quite little guidance to support yourselves as primary care clinicians on how to up or down titrate medication depending on how the patient is presenting in front of you. And, oftentimes 10 minutes isn't really enough to do like a thorough assessment on somebody that you may see once a year, and I can completely appreciate that as well. And the main question is like, what support is out there for yourselves? And it's quite tricky, I suppose, in terms of psychiatry, because as a general rule of thumb, it does all depend on the patient. But I think it's just to be mindful that medication is only one aspect of the treatment for most mental health conditions. And oftentimes I find that when I speak to patients, that many of them have quite unrealistic expectations on what medications can help them with, particularly for those on antidepressant treatment as well. I think some useful guiding principles always to be mindful of when thinking about changing a psychotropic medicine is probably what target symptoms are we using the medication to treat? And that's a question that I ask even the psychiatrists at work a lot of the time, in terms of in the inpatient setting. We start a medication, we need to look at what target symptoms we're using to treat, because otherwise we can't tell whether the medication has been beneficial for the individual or not. Sometimes I also recommend using rating scales, such as like GAD-7 or PHQ-9 for mood type symptoms. Perhaps using like an assessment scale for the side effects, like the GAS scale, which can guide you in terms of potentially down titrating the treatment. An assessment of physical health. Obviously, if the medication is impacting their physical health, you may want to adjust the medication as such. And also slow and steady wins the race. We don't need to quickly get someone off medication. And oftentimes you can see the process tends to take months or even sometimes years as compared to days or weeks. And I'll probably also say that the NICE guidelines are always your friend. There's quite a lot of useful information in most of the NICE guidelines to support with adjusting medication. And again, not to kind of promote my service too much, but I'm more than happy to provide kind of general advice in terms of, okay, I'm thinking of doing this. Is this right? Yes or no? And just give a little bit of extra advice or specialist advice from that sense as well. Any questions on that so far?
Well, yeah, just related straight to that point about availability to answer questions. Jonathan Tomlinson asked, we quite often have patients, new patients who have come from abroad on multiple psychotropics, especially from the United States, and might need advice quickly on what to do. Would you be available for advice?
Yeah, I'm more than happy to provide advice. Particularly, I know I have gotten a lot of referrals recently about patients that come from America or abroad or other private psychiatric clinics, and they need clinicians need advice about adjusting the medication. So more than happy to provide that kind of advice as well.
Maybe you can share your email address at the end.
Yeah, it's part of the slides at the end.
Great.
So it's definitely there for everyone to utilize. So that's fine.
Great. And Denise, a suggestion for medicines reconciliation would be, if possible, for each practice be sent a list of the patients who are receiving depot antipsychotics, and our practice pharmacists or technicians can put this onto EMIS medical records as hospital only. if they're not on our systems.
Yeah, that would be useful. I can see that Jonathan's put my personal email address on the chat, but it's just to be mindful there's a separate one for clinical inquiries, and it's just more in case I'm on annual leave and that doesn't get captured as well, because I'm the only pharmacist for the service. That was all.
Thanks, Brenda.
Yeah. So that's fine. And then I guess coming to kind of tying in quite nicely from Jonathan's question, actually, just about a brief overview of kind of the types of questions that I've seen recently from referrals, just from my last 2 months in practice. So oftentimes, these were probably the 4 most common things that I've seen so far in the 2 months. And was there a hand raised? Sorry.
Medication.
I don't think so.
All right. Okay. No, that's fine. Yeah. And so I guess the first one was just about requests for a prescription of psychotropic medicines from non-conventional. I say non-conventional sources, so basically not from else. So for example, like private psychiatric clinics and patients coming from abroad or other trusts as well. I think oftentimes when I've looked at the referrals, there's often a lack of description on the patient's current mental state. So it would be useful as well when I'm referring to us to have a bit of detail about the patient's current mental state, or even like any kind of previous clinic letters from these other sources, for example, like the letters from the private psychiatrist or kind of transfer letters from other trusts or the patients that come from abroad. I can appreciate sometimes this may not always be available. However, it does help to support us answer the question much quicker, just so that we can make a good judgment on, yes, it's fine to continue, or no, it's not fine to continue. And oftentimes as well, I suppose, it's just making sure that if you have cast eyes on the patient and, you are concerned about their mental health, and if it's not really within the recommended guidelines, but the patient's mental health is stable, there's lots of different factors, I suppose, which would come into play. So I think just as much detail as possible would be really helpful in terms of us providing that answer quickly to yourselves. The next one was just about next steps in antidepressant treatment. Again, what might be useful is that sometimes I get referrals that the patients tried sertraline, the patients tried citalopram. So what do we do next? Or the patients read about bupropion and they want to start on it. So what do we do in this instance? And I guess, again, about details on the current mental state would be really useful. Also, some details about response to the antidepressant and duration of trials of antidepressants would also be really useful in terms of guiding further recommendations. So that was the other thing that I've noticed a lot in the referrals. And again, I can appreciate that it might be quite time consuming to collate all this information initially, but it saves us having to kind of bounce back the referral to say we need more information as well. I think there's some questions.
One is a link which I can't click on right now because it's taken out of the presentation, so I'm not quite sure. The other one is a question from Phil. Is there a route for getting advice from neighbour referral meeting without attending? Right, yeah, I can answer that. Yeah, if you send in the details of the patient and you don't attend, then they will still be discussed, and advice will come back and a plan for the patient. So you don't have to attend, but it might be useful, if there is a discussion that you want to have, to get some advice there and then.
Yep. Then the third one was just about ADHD diagnosis, assessment, and treatment. I would say that the current wait time for an ADHD assessment for someone without a diagnosis is actually quite long for adult ADHD. I think the service is giving a lead time of 12 to 18 months for to get an assessment for diagnosis. So that can be quite tricky. And a lot of the time as well, for those referrals that we get, we don't tend to see kind of like developmental history or kind of the AQ10 things that are being, I think it's a different scale that I'm thinking of, AQ10. Just kind of like the things that are stated in the referral criteria haven't been attached with the request for an assessment. So in the end, those referrals do get bounced back as well. On the flip side, for patients who have been transitioned, for example, had a diagnosis of ADHD in CAMHS, and they do just need follow-up in adult services, what might be useful to include in the details of the referral would be that this patient has already have an established diagnosis and they've been seen in CAMHS and they just need a follow-up in adult services, and that kind of expedites the referral much quicker, and I think the patient can get seen much quicker. In addition to that, anyone who's already been established on ADHD treatment, for example, from abroad, or also from another trust, again, including those details in that referral as well would be really useful as well. Yeah, so, and then the last one was about medication options for transitional patients. So kind of those that are transferring from like CAMHS to adult services. I had a referral recently for a gentleman who's just turned 18 years old, who's tried fluoxetine and ongoing low mood and suicidal ideation. However, there wasn't much detail in terms of like what other options have been explored. And I think it can be quite tricky in that transition period, I suppose, because of the licensing of medications and also selection of medications, where maybe some patients might still have quite a lot of involvement from their parents and some less so. So I guess it's just more to kind of give a bit more detail and context again about mental state, what's been tried. And yeah, think that was kind of what I've seen so far in practice, and, you know, more than happy to kind of collate this every 3 to 6 months and give like an FAQ to yourselves if needs be. So the next thing was just about some work that I'm hoping to start up and like discuss as well, and maybe just getting some expressions of interest or ideas from yourselves as primary care clinicians that, you know, I think there's lots of work that is being done and focused on psychotropic prescribing for patients not on the SMI register, and how we can support the deprescribing agenda. Also just about upskilling primary care teams to support review of stable patients on the SMI register. So for those who don't really have any involvement with secondary care teams, and how we can support primary care to maybe have a bit more skills and confidence to review these subset of patients. Also just about improving the quality of discharge summaries and discharge planning to primary care, and probably would just love some feedback in terms of what might be useful to be included in the discharge planning and discharge summary. And I guess going forward in terms of the wider mental health transformation project, it's just about supporting mental health in older adults, which I think is kind of a untapped area so far within the neighborhoods project as well. So just kind of any ideas on what could be done might be useful as well. So I think that's it from me. So the contact details, again, I've put this one, ELF PCN Pharmacy. So that's kind of the mailbox for any kind of PCN related medication referrals, so that can get sent directly to myself and I can take a look at it. And then this is kind of the email for the single point of access for any referrals as well. Yeah, and I'm just going to post a link to the for a feedback form as well, or I might send it to Alana to circulate if everyone could, you know, kindly fill in the feedback. I would really appreciate it, as it's my first time I'm delivering a session like this. So it'd be great to hear what you thought of it and how it could be improved as well.
Thanks so much, Alana. So Brenta, that was great. I managed to open up the link that somebody sent, which was for the City and Hackney Mental Health Alliance winning the HSJ Award for Mental Health Innovation of the Year. I don't know if that was in response to a particular point that you made, or just wanting to celebrate that achievement more generally.
I'm not too sure because I don't think I posted that link. I think definitely that SMI reviewing psychotropic medicines who for patients weren't on the SMI register was some good piece of work that was done within the CCG. And I think that was one of the awards that they received for that as well. And I think it's just kind of building on that good work and kind of continuing on that good work as well, if I'm not mistaken.
Great. I don't know if Alana might, who's sorting out the IT for this session, might propose something different, but somebody said earlier, could we open up the chat? And I'm aware that, you know, when a question is posted, we might answer it and maybe we might want to come back on it and you don't have that opportunity. Maybe I can suggest that if you do the raise hand function, and then we can, I think, unmute you so that you can actually speak back to us in that situation. That might be the best way to solve that. And you can also use the Q&A function. You know, it doesn't have to be a question necessarily. You can just post a thought on there if you want to. So we'll go back to the questions on the Q&A, but just on, you know, somebody
I'll stop sharing my screen as well. Yeah. So
Mayuri has raised her hand. So I'm just going to see if I can figure out how to allow you to talk. I think I've done it. Do you want to go ahead, Mayuri, and try?
Yeah, so actually it was myself that posted that. Thank you very much for this talk, Brenda. It's really fantastic. I'm here from the medicines management team. I don't know if anybody else is here, and with the view to putting some of these things in the prescribing newsletter, really about supporting GPs, how they can access the advice that Brenda has. With regards to that work around SMIs, you know, that basically that was me that posted the link to say that good works has already been done around the physical monitoring, and an audit was run a few years ago on antipsychotics for people who are not on the SMI register, and that we identified quite a few people there that we managed to get off. So support in that area with the deep prescribing is really appreciated.
Great piece of work. Thank you very much. So going to the Q&A, Jonathan Tomlinson, reviewing ADHD meds could be useful given how much is being initiated outside of CMHT and continued in primary care, also pregabalin and benzos and Z drugs.
Would that be in terms of like a guideline, or in terms of reviewing ADHD meds could be useful given how much?
Should I allow Jonathan to talk if he wants to?
Yeah, that might be useful.
I think you should be able to talk, Jonathan. Are you there? Perhaps he's gone off. Maybe we'll come back to Jonathan. Let me just mute him for a minute. Phil, do older patient referrals go through the neighbourhood pathway too?
Yes, they do, and I think they do. There is like a nurse from the older people's team that also get that has input to provide advice as well. And I think that's kind of something that we're looking to explore in terms of how that link will go forward in terms of the wider neighborhoods teams model.
Thank you. Denise, some support getting patients to come in for annual health check with our practice nurse or the mental health HCAs would be helpful. More around recall, as patients are sometimes reluctant to book or don't tend to respond to letters or text invites.
There is a service within the CMHTs at the moment, and I do know for the South Hackney CMHT, there is like a link nurse that supports in terms of very difficult to capture patients. I can try and get that email address out, but I guess it's just more as the neighborhoods team and the CMHT model is changing. I'm not too sure where that service will sit over time as well, but certainly if there's any patients immediately that need to be captured, you know, Adam can be contacted in that instance, and I'll send all the details to Alana as well, or I'll just make like an additional slide in the presentation and forward it on later.
Yeah, that'd be really helpful. Thanks, Brenda. I don't know if Jonathan is there. Did you want to come in, Jonathan?
I think that's better. Hi, can you hear?
Yep.
Yeah. I'm just struck by how many patients are diagnosed and initiated on drugs for ADHD in the private sector, and then are continued once we've received a shared care agreement. And they're usually discharged from the private psychiatrist as soon as they've had their diagnosis and being initiated. So the only kind of treatment as such that they're offered is the medication. And I was just thinking that throughout the whole of Hackney, there must be hundreds of people in this situation. And I just wondered whether it would be useful at a borough-wide level to be kind of assessing the degree to which this is going on and thinking about whether there's other kind of monitoring that perhaps we ought to be doing.
I guess with Hackney, we're quite unique in the way that we do have a separate ADHD service compared to like the other mental health conditions as well. So that's something I can really take back to the ADHD team just to see if it's something that needs to be looked at on a wider perspective as well, because there's not really a dedicated pharmacy team within that service either. So I think that's something that I can at least link in with their team just to see what their thoughts are as well.
Okay. And the other drugs that are used widely, gabapentinoids, benzos, and zopiclone and zimovane are very frequently co-prescribed with psychotropic drugs. And I just wondered whether, as part of the work on psychotropics, that could be included.
Yeah, and I suppose, is it more just in terms of like advice and support on how to deprescribe, or is that more in the sense of
yes, I think so. Our clinical pharmacist and one of the GPs in our practice is doing a huge amount of work with that, with great success actually.
Yeah.
But I just wondered whether that could be supported beyond one particular practice.
Yeah, and I think that that's definitely a really great feedback to get, Jonathan. So thank you so much. So that's something that perhaps I'll look to work with my other colleague, Dorcas. She's the dedicated pharmacist for London Fields PCN. So perhaps that's something that we might need to look at in terms of like a bigger piece of work, and whether it's guidance that we need to publish, or if it's, you know, individual patient queries, more than happy to support on a patient by patient basis initially, and then kind of, you know, look to see if having like some sort of guidance might be appropriate over time as well.
Thank you.
Anybody else want to make any further points at all? Please raise your hand now, or otherwise we'll move on to Mayuri again. Let me just, I think you can talk, Mayuri.
Yeah, thank you. Sorry, the last point about the Z drugs, there is an ELFT hypnotics deprescribing pack that we have. It's a few years old. Brenda, I don't know if you want to look at that again, if you want me to send you a link to it.
Yeah, that would be helpful, Mayuri. So yeah, we can maybe take a look at that and kind of, you know, discuss it amongst, you know, the medicines management team as well, and just to see what things that we can do to support and whether that just needs to be extended in terms of like gabapentinoids and other medications as well.
Great.
Yeah, perfect.
Any more, or shall we move on to the CAMHS? Did you want to say anything else, Brenda?
No, other than I've just put the link to the feedback form in the chat. So really appreciate if everyone could, you know, who's attended the session could fill it in, just more for, you know, for anyone else who's, you know, if we do get invited to deliver a similar session, you know, just some feedback on what may or may not be helpful for future sessions, I suppose.
Great, thanks so much for your presentation today. It was really helpful.
Oh yeah, thank you so much for having me. So yeah.
Great. Oh, there's one more, just a thank you in the Q&A. So I'm going to move on now to, is Kirsten Mitchell there?
Hi, James. Yeah.
Hi, Kirsten. So Kirsten's going to talk to us now about SSRI prescription in children and young people. Thanks, Kirsten.
That's all right, I'll just share the screen. I think that's all set up so that everyone should be able to see it. Hi everyone, as James has already mentioned, my name is Kirsten. I'm one of the child and adolescent consultant psychiatrists working at City and Hackney CAMHS. So myself and also Kate, the doctor who'll be presenting after me, were asked to do a bit of teaching, myself about SSRIs and prescribing in children and young people, and Kate thinking more about ADHD and prescribing for children and young people and ADHD. I'm aware that GPs already have a lot of experience prescribing SSRIs in the adult population. And I guess what I've tried to do in this presentation is think about within the CAMHS population, what we do in CAMHS that maybe GPs aren't aware of. Maybe you are, but I can be keen to hear more about that. And with the hope that that is helpful for you as far as understanding perhaps when young people may need to be referred to us to think about SSRIs or other treatments in general, when queries might come up from young people that you're not sure whether or not it needs to come to us or they need a review or what else might be helpful for them in those situations. And I guess generally just sort of a reminder as well about how prescribing SSRIs in young people is different from prescribing for adults. And I've touched on that quite a bit in the presentation. So I wanted to have a bit of an interactive beginning to the presentation, but what we might do is swap it around and do the interactive bit at the end, because it seems a bit tricky to do it in this setting. But I do want to hear a bit about your experiences of prescribing SSRIs, particularly in children and young people. And then I'm going to talk a bit about when to consider it at all, which SSRIs are used to prescribe for young people. And then I've gone through a few specific disorders, when to consider an SSRI and what to use in those situations. And then what I've done is taken you sort of step by step through the bits that we would do in CAMHS that maybe you are aware of, but wouldn't necessarily be responsible for doing yourselves with children and young people. So, I mean, should we give it a try and see if maybe people want to raise their hands, and James, maybe you can help out with this. Just if anyone wants to share their thoughts or experiences so far of prescribing SSRIs in young people.
Yeah, wait to see if anyone raises their hand. I mean, my personal point of view is I wouldn't be initiating prescription. There's more to, as you said in your introduction, about knowing when to refer to you guys, and people who might already be on it, about sort of problem solving and things, and when it needs to kind of go back to you guys. But I don't know if anybody else, nobody seems to be raising their hand. So maybe we'll come back to that at the end if there's a question popping up. And yeah, Jonathan Thomason, I've never started them in anyone under 21, 22 in over 20 years as a GP. Probably, and
that's exactly what we would expect at this point. Yeah. So that's good to hear as well. Right, and then I guess the other part to that question is, and I think James, you've just touched on this a bit already, but what might be helpful to know if anything has been difficult or concerning, anything that came up when, because I know GPs are often asked to take over the prescribing, not the monitoring, but the prescribing of young people on SSRIs, whether anything's been particularly difficult for any of you with regards to that, or if there's just anything else you'd like to know.
Nothing coming up, Kirsten, but having looked through your slides already, I think you answered a lot of the questions that I wanted to know in the slides.
Okay, we'll move on then. That's great. So just first of all, I wanted to mention the key diagnoses that we would consider prescribing SSRIs for in young people. And I'll say young people, but this applies to children under 12 as well. So depression, which probably doesn't surprise anyone, anxiety, obsessive compulsive disorder, and body dysmorphic disorder. I've lumped those together because under guidance, they're lumped together as well. Post-traumatic stress disorder is an interesting one, but I've included it, and we'll talk a bit more about that. And then I've also popped on here eating disorders because SSRIs are quite commonly prescribed as one of the medications to treat eating disorders, but I've not covered that in this presentation because it is quite a large topic to cover. And so again, this probably comes as no surprise to anyone because I know often people do take over the prescribing of SSRIs, but the most commonly used SSRIs in this population are fluoxetine and sertraline. And for the most part, they are the only two SSRIs generally prescribed in under 16s and even in under 18, but with a bit more flexibility there. So as I said, I've talked through a few different diagnoses and thinking about when someone with this diagnosis might get prescribed an SSRI if they're under 18. The first one I'm going to think a bit about is depression. I know that's quite a busy slide, but what I wanted to do is just remind people of the criteria for a diagnosis of depression and the fact that it is divided into mild, moderate, and severe depression. And so I won't read off the slide, but essentially what you're looking at is the number of these symptoms that a young person or child may be experiencing, and then being able to quite easily categorize that into mild, moderate, or severe depression. Of course, it's not ever as easy in real life with any of the young people we meet, but if you can vaguely fit symptoms into those categories, you're coming from a good starting place for thinking about whether or not prescribing might be helpful. So I've talked quite a bit about NICE recommendations because generally that is what we stick to in CAMHS services, again with a little bit of flexibility. And if Brenda's still listening, I'd be happy if Brenda also has any thoughts about some of the prescribing practices we have to hear about those. Essentially, NICE recommends that in 5 to 18-year-olds, the first line intervention for depression is psychological therapy. And that's across the mild, moderate, or severe depression categories. SSRIs are not recommended in particular if it's mild depression. And what they do say is that actually someone with the diagnosis of mild depression should be given at least 2 to 3 months of psychological therapy before even thinking about SSRIs. In moderate to severe depression, you can consider an SSRI if there's no shift in mood after 4 to 6 sessions of therapy. And that's meant to be the appropriate psychological intervention. So I won't go into lots of detail about psychological interventions, but it's not helpful for a young person to have a psychological intervention that's not meant for depression. So it has to be focused on the diagnosis that they're given. And then after 4 to 6 sessions, you would likely want to meet with the clinicians who are working with the young person and consider next steps, one possibly being prescribing an SSRI. In cases of severe depression, and I will say this does happen sometimes in CAMHS, not always, but occasionally, you might consider starting a combination of an SSRI with the appropriate therapy. And always the first line SSRI for depression in anyone under the age of 18 is fluoxetine. And then yes, just to say that SSRIs for depression in this age cohort should always be concurrent with psychological therapy. So whether or not the SSRI is started at the same time as the therapy, which again is rare, but sometimes does happen, or after a review, after 6 sessions, or after 3 months, the therapy should continue to the end of the course of the therapy. And that's because the evidence is that whilst SSRIs are helpful and therapy is beneficial, the combination of the two shows the most effective response. The slides seem to be frozen. There we go. So as I mentioned, when we're thinking about depression, fluoxetine is the only SSRI licensed for 8 to 18-year-olds for depression in the UK. It's because it's the only SSRI that there's evidence for which the benefits outweigh the risks. And when we say risks, we mostly mean side effects of the medication. In our population, we generally start at half the dose, so 10, that should say 10 milligrams, that's a very bad error there, that should say 10 milligrams. And and that they should be on that dose for at least 1 week. That's what the guidance says. I normally give it 2 weeks and then think about increasing to 20 milligrams. And what you're doing in that period is seeing if there are any side effects, seeing how severe they are, seeing if it is possible, if the young person can even tolerate going up to the higher dose, or if they need to stay at the 10 milligram dose, or if we need to think about a completely different medication.
Do you mind if I ask a question there? Do you mind if I ask a question there?
Yeah, of course, yeah.
I mean, in my own prescribing in adults, I thought like 1 week would seem too short. Even 2 weeks, I'd be surprised to see if you're really getting the beneficial effect of that dose. I tend to sort of leave it a longer amount of time, but it'd be interesting to know what you think.
Yeah, and so this is, and the guidance says 1 week because in the child and adolescent guidance, what they're looking at really at that 10 milligram dose is whether or not there are severe side effects.
Right.
Because the evidence shows that the treatment dose, the 20 milligram dose, is what is going to be effective.
I see.
Does that make sense? So you're you're wanting to get up with fluoxetine to the 20 milligram dose, but doing it safely as possible.
Makes sense.
But every case, we do take every case by case. And for some children, particularly those under 12, it may be that they're on 10 milligrams and it may be that you want to leave it for longer. So maybe a month before thinking about increasing it.
Thank you.
That's okay. And then, so sertraline, which is the other SSRI, pretty much the only other SSRI that we commonly prescribe in CAMHS, is used as a second line for depression. It is off-license use, so that means that it should be documented and families should be made aware that that's the case. And again, we normally start at half the expected treatment dose, which would be 25 milligrams. And again, in children younger than 12, I almost always start at 12.5 milligrams and slowly increase. And the interesting thing about sertraline, or the helpful thing about sertraline, is there's lots of scope to increase the dose, and that even in someone under the age of 18, you can go up to the full dose of 200 milligrams. It's rare, but you can do. So it sometimes it's a little bit, you have to be a little bit more careful when you're initiating it and monitoring it. And with sertraline, I do tend to give slightly longer than a 2-week period on the 25 milligram dose. And I certainly wouldn't go over 50 milligrams anytime sooner than a month, because as James was saying, it would be really unlikely that you'll see the beneficial effects prior to that time period. And actually with sertraline, even at quite a low dose, you can start to see beneficial effects. And then citalopram, again, it's off-license use, and it would be really rare for anyone to be prescribed that for depression in CAMHS unless they're coming up to their 18th birthday and for any reason they've not tolerated or not responded well to fluoxetine or sertraline. So again, it's rare, but occasionally it is prescribed. And again, you start at half the dose normally. And then thinking about when to stop an SSRI. And I think this sometimes maybe is more relevant to GPs prescribing, not necessarily for children and young people, but those young people who maybe are started on an antidepressant when they're coming up to their 18th birthday. And I know now with the neighbourhood team, the responsibilities and roles are slightly different, but that you might be in the position of having a discussion about stopping an SSRI with someone who's turned 18. And the general guidance, and we do follow this quite closely in CAMHS, is that if someone has responded to fluoxetine and so they use the word remission, which is defined as no symptoms and full functioning for at least 8 weeks. So after that 8-week period of full functioning, they should stay on the medication for another 6 months. And again, it's guidance, and it is the sort of framework that we work in, but it's certainly case by case. And young people, I know young people to be on it for a shorter amount of time and for much longer. And yeah, and I've just made the point that 1 year, I'd say, is a pretty good estimate. And that's normally what I say to families, that by the time you started to feel better and have had that 8 weeks, and then 6 months on top of that, it's normally about a year. So moving on now to anxiety. And I haven't gone through the diagnostic criteria for the different types of anxiety disorders, but I've included what they are here. So we'd be thinking about generalized anxiety disorder, social anxiety, specific phobias, and panic disorder. And I guess the important thing, rather than sort of going through all the diagnostic criteria for these, is thinking about the impact of these on how a young person is functioning. So that could look like, are they leaving the house? Are they able to attend school? Are they seeing friends? Is it so extreme that they're harming themselves? So sort of really thinking about not just the diagnosis itself, but the impact it's having on these young people. A, when you're thinking about whether or not to refer to CAMHS, and then B, when you're thinking about prescribing an SSRI, or when you're thinking about doing that. So as I've said, generally nice guidance is that SSRIs should not routinely be used in the treatment of anxiety in those under 18. And that is across the disorders that I've just mentioned to you. However, there are two scenarios in which we do commonly use it when we're prescribing in CAMHS. And again, both would follow the same guidance as depression in that it should be concurrent with psychological therapy and that the first line medication to use would be fluoxetine. And those two scenarios would be when the anxiety is comorbid with moderate to severe depression, and when anxiety is having a significant impact on how the young person is functioning and it hasn't shifted within 4 to 6 sessions of therapy. So again, when thinking about significant impact, some of those examples that I just went through would be what you'd want to have in mind when you're considering whether or not to start an SSRI. Another one that I didn't mention on the first slide is not eating secondary to anxiety, because of course that has serious physical health consequences as well. And the other one that, so James mentioned that I work in our pediatric liaison team as well as our emotional and behavioural team here at CAMHS. And within the PLT, we see lots of somatizing and functional symptoms that are associated with anxiety, and that those are the symptoms rather than necessarily the anxiety that's having an impact on someone's daily functioning, but thinking about those types of symptoms as well. And if they are having a severe impact, we might think about starting an SSRI. So with anxiety, because it's not generally used for anxiety in under 18s, there's less guidance about it. But I think about it in the same way that I think about depression, where we're always looking at improvement and then giving it 6 months after recovery. So moving on now to OCD and so obsessive compulsive disorder and body dysmorphic disorder. And these two diagnoses are often lumped together because although different, they're both linked to having intrusive obsessional type thoughts. And so whilst the treatment is not exactly the same, it's quite similar. So as I've just mentioned, and just a reminder of the diagnostic criteria of OCD, again, I'm not going to read out the whole slide, but there are two things that have to be present in order to make a diagnosis of OCD, although the guidance has, the criteria has slightly changed on this, but the one that absolutely has to be present is obsessional or intrusive thoughts that are distressing to the young person. The young person is not able to resist them, and they're recognized as their own thoughts, but the thoughts are very upsetting to the young person in some way. And the other thing that has to be present generally, but I think has sort of been, it's still often there, but it's been agreed that a diagnosis of OCD now can be given even if the rituals or compulsions are not there, if they meet the obsessional thought criteria. However, you do often also see rituals or compulsions, and they're generally stereotyped and directly linked to the intrusive thoughts that the young person is having, and doing these rituals tends to alleviate the anxiety that comes with those really distressing or discomforting intrusive thoughts. And anxiety is almost always present within this disorder as well. So BDD, the criteria are much less rigid, but essentially you're still thinking about obsessional and intrusive thoughts that are related to appearance and preoccupations. They talk about repetitive behaviours as being a criteria as well, but these can also be cognitions, so repeated cognitions about a particular part of your appearance. And the behaviours or cognitions have to be related to the appearance concerns. And finally, the preoccupation must cause clinically significant distress and or impairment, which is similar to when we're thinking about OCD and anxiety. So again, with OCD, and I've sort of lumped it, as I said, together with BDD, but I'll separate them out when we're thinking about the SSRIs. The nice guidance, again, is psychological intervention as first-line treatment. Surprisingly for OCD, which in my experience can deteriorate quite quickly and become a disorder that has a significant impact on a young person's life quite quickly, the nice guidance suggests that you should have a full 12-week psychological intervention before even thinking about SSRIs. If there's moderate to severe impairment in function and no response to appropriate therapeutic intervention, this is when they suggest you consider an SSRI. And then if there are severe symptoms, you might consider combined therapy in a similar way to you might do with severe depressive disorder. I think the tendency actually in CAMHS is to start medications sooner than 12 weeks if there's moderate to severe impairment from the outset. And occasionally, even in quite young children, if the impact is very severe, then we'll start an SSRI almost as soon as the therapeutic intervention has started. And that is just because we know that those symptoms can deteriorate very quickly. With OCD, the SSRIs that are licensed are sertraline, which is first line for OCD, and then also fluvoxamine, which is a less commonly prescribed SSRI in general. It's certainly not prescribed for any other diagnoses in CAMHS, but it is the second line for OCD when you're thinking about this population. And then fluoxetine as well. Generally, that's the first line for body dysmorphic disorder, although sertraline can also be used. And that it is the first line for OCD that's also combined or comorbid with severe depression. So really what you're wanting to do is understand not just that the young person has OCD, but what the obsessional thoughts are about and whether or not there are comorbid diagnoses before you're ready to make that decision about which SSRI you should be prescribing. And sertraline is thought to have the most beneficial effect on intrusive thoughts, which is why it's first line in this disorder. Then again, the recommendation is to continue approximately 6 months after full remission. They do extend the full remission period to be slightly longer with OCD, so 12 weeks instead of 8 weeks. So I've added in post-traumatic stress disorder, which is a bit of a sneaky one, but the main reason that I've added it in, so again, I won't go through all of the criteria, but as a reminder, there has to be exposure to a stressful event, and it's an event that most people would find stressful, and that's likely to cause distress. And then it has to be relived through flashbacks, and then there are other symptoms that you may experience, and you have to experience at least 2 of them for it to be post-traumatic stress disorder. You also have to think about timing with post-traumatic stress disorder. So you're not supposed to make a diagnosis within 1 month after the traumatic incident. And generally, we think about 3 months as a time when someone might be ready to start thinking about having any psychological work for a traumatic incident. So first line, as I mentioned, is trauma-focused CBT. And as I said, usually 1 to 3 months after the event. What I have highlighted here is that the guidance is that SSRI should not, it doesn't even say generally shouldn't be or shouldn't routinely, it says should not be used for treatment of PTSD in anyone under 18. And I highlight that just because it is different to adults, where sertraline is recommended as the first line SSRI. But it does happen in practice that if someone is 16 or 17 and is not improving with any form of therapeutic intervention, you might consider prescribing sertraline for PTSD symptoms, even if they don't meet criteria for depression or anxiety. And that's essentially because SSRIs haven't been shown to be effective in children and young people with a diagnosis of PTSD, which is interesting. And I guess it'd be good to understand more about that. But I think some of the thoughts behind that are around development of the brain and what parts of the brain can be affected as part of a diagnosis of PTSD. So actually, if we want to pause here and see if anyone has any questions about any of the diagnoses that have been discussed so far, this might be a good time to do it.
A couple of questions have been, well, a point and a question have been answered. Imran said in the moderate to severe category, I think it means anxiety, but maybe depression. Is fluoxetine not more likely to exacerbate anxiety symptoms, or is this just a short-term effect? And Brenda's come back saying that it tends to be a shorter-term effect. It goes away with time, but recommended sort of more frequent follow-up initially. I don't know if you want to add anything else to that, Kirsten.
Yeah, no, I was just going to say exactly that it can be seen as a side effect. It's not a really common side effect, but if it does occur exactly that, then you'd want to monitor it quite frequently and make sure that if it's not subsiding within a couple of weeks, to consider maybe trying sertraline instead. It is an effect that tends to wear off though.
Jonathan sent a link to a Lancet article that says made him shift his expectations to expect a difference with SSRIs in 10 to 14 days.
Yeah, and so I can't see any of this. Where are you seeing it?
This is on the, it's in the Q&A, but it's in the answered section because.
Sorry. Okay. Yeah. Yeah, and so yeah, I tend to say 4 weeks to families when I'm meeting them because it's unhelpful to give a young person the idea that if in 2 weeks you don't see any beneficial effect, then this isn't going to be helpful, because sometimes they do and sometimes they don't. Yes, we do know that sort of between 2 and 4 weeks is when you might start to see beneficial effects. And great if we do, but we still sort of are cautious about it when we're explaining it to young people and say about 4 weeks.
Great. Brenda's just raised her hand. Do you want to come in, Brenda?
Oh yeah, I just wanted to add, in terms of what Kirsten has said so far, I know she wanted to get some thoughts from pharmacist perspective about the use of medication in children and young person. And I think I put it in the chat, but it said to the host and panelists only. So basically nobody's seen it. But I think just from experience is that we do tend to see a lot of the time that, focus on using medication as just kind of like the core treatment in terms of all these conditions in children and young people, and even for adults as well, because it's almost like a quick and easy route for management. And, like previous experience working in CAMHS, we definitely tend to see like more psychological therapies, but access to this, like Kirsten's highlighted, can be quite challenging. And I guess just to be mindful as well with kind of the children and young persons cohort as well, in terms of like social media and all these kinds of things, how that can affect their mental health, and kind of like managing those expectations as well in terms of like when they start on medication. And it is kind of like having to be a bit cautious and taking all these kind of external factors into play as well when using to treat medication. And rightly, as Kirsten said about, how is it impacting this person's life as compared to focusing on the diagnosis and treating just like the label, and more looking at the individual and supporting that individual to the best of their ability, really.
Thanks, Brenda. Mayuri wants to say something, so I'm just going to allow her to talk. Go ahead, Mayuri.
Thank you. I was just following up on Brenda's point. Last year, MMT ran a prescribing audit in practices in children under 18 and in the 18 to 25 age group. And what we found was that the therapy, the psychological interventions weren't really taken up very much in the young age group. That may be that there's long waiting times that they don't take the service up. It may be that they're not present enough, or they need carer support to do these things. But generally, the antidepressants tend to be started first, and there's no evidence or any follow-up in practices of whether the psychological interventions have happened or if they've had any benefit. So it very much repeating Brenda's point that the SSRIs, the antidepressants, are often first port of call. And there isn't enough signposting of the services that we have available for young people to support them through these difficult times.
I do wonder as well if there's an element of communication not happening as far as the psychological therapies that a young person's being offered. And I'd be surprised, at least in our service, when we're thinking about SSRI prescribing, not other medications, that the young person hadn't at least be offered and tried to engage with any psychological therapy at all, even if it was maybe within the first step service prior to being referred to specialist CAMHS. So that's a really good point. And I do now remember James sending me the audit, and I haven't included any of the information in here. Sorry about that, James.
Yeah, no, don't worry. I was just going to come back on that. I think it was mentioned from the CAMHS side of things that although the audit results showed that that they thought that probably it just may not have been relayed in a letter, that actually psychological therapies have been a part of their treatment as well. So the audit results are maybe slightly misleading.
Well, yes, it may not be documented. It may be a case of just what we saw on the EMIS. But usually, if the children are following the sort of official route via ELFT, then there was lots more documentation of the psychological interventions. But I wonder if GPs also see children who don't get referred and what support they have in terms of psychological interventions, if they always happen.
Yeah, and that's a very good point. Sorry. And I do wonder if we need to think a little bit more carefully as well about how the information is communicated, and thinking about those that don't come sort of through the traditional ELF referral system as well, and what's happening with them. I can see as well, I'm wondering actually, so I've got just a couple more slides, and what these slides do is sort of talk through like the 4 steps of different types of medication appointments that we would have when thinking about starting an SSRI. I'm not sure that this is hugely different from what someone would do when prescribing for an adult, apart from maybe some of the monitoring requirements. I'm aware we don't have loads of time left, so I wonder if actually people would rather just want to use these sort of last 10 minutes with questions, even last 5 minutes now with questions.
Thanks, Kirsten.
And then the slides will be made available to you.
Thinking similarly, yeah, I think that would be helpful. The discussions are often very useful. So Jonathan has made a couple of points in the Q&A. What age is clomipramine considered for OCD, ADD?
That's a good question. We almost never prescribe it for OCD in CAMHS anymore, though I know it previously has been prescribed. And I'm not sure, but Kate might talk a bit about it with ADHD. So I don't actually know the answer to that question, but Brenda might know as well. But if
yeah,
not,
I guess because clomipramine is kind of like a tricyclic antidepressant, there's kind of increased risks of using that in kind of younger persons, including like anticholinergic risks, as well as kind of, although clomipramine is considered one of the less risky options in overdose, there's more potential than to cause harm in comparison to like an SSRI, for example. So definitely kind of more looked at in terms of like an adult population compared to young person population.
And then I can see Jonathan's also asking about complex PTSD and
I've just allowed Jonathan to talk, actually. If you wanted to come in and sort of expand on that, it might be a bit more helpful.
Yes, I see kind of more adults and children who have kind of complex PTSD than single event PTSD, and certainly more adults, and also a lot of them also have co-existing dissociative identity disorder or quite marked dissociation, and almost as frequently in adults and less so in children, I think, but maybe in adolescents and young adults, functional neurological disorder or symptoms. And I just wondered whether you could talk about whether you distinguish these conditions and whether there's different types of treatment that you haven't mentioned.
Sure. So with complex PTSD versus PTSD, the answer is yes, diagnostically, we would differentiate them. And we think it's particularly, or I say we, the team that I work in, the emotional behavioural team, not we as a profession, but we do have a lot of discussions about diagnosing complex PTSD and the helpfulness of it, erring on the side of it actually being quite helpful if it's appropriate diagnosis to give, because a lot of the symptoms can overlap with emotionally unstable personality disorder, which you wouldn't normally diagnose in someone under the age of 18. But nevertheless, I think it's a helpful diagnosis to have as far as highlighting some of the complex trauma that this young person has been through in their life as they move on into adult services, where they might be more likely to get a diagnosis of BUPD as well. So diagnostically, yes. Treatment-wise, not as much. The idea would still be to have the trauma-focused CBT, and if needed, think about an SSRI. With the SSRI, we might be thinking more about whether or not there's comorbid severe depression or comorbid anxiety as well, and prescribed based on those symptoms rather than the complex PTSD itself. With DID, we don't generally diagnose DID in CAMHS, although we have had an interesting case recently of someone who possibly has some symptoms, and we've had quite a few discussions about it. But medication-wise, again, you wouldn't necessarily be wanting to treat them with an SSRI unless they met the criteria for one of the other disorders that an SSRI is helpful for treating. In this case, because we think there's comorbid severe depression symptoms, we have started an SSRI for this young person. But when you look at the guidance for DID, from what I can remember, there's actually no recommendation for medication unless it's to treat a certain symptom, like depression or psychosis. Functional neurological disorder, we do see, of course, a lot of in the pediatric liaison team. And in short, the answer is yes, SSRIs are something to be considered. It's not always as easy because, and again, I don't know, I'd imagine GPs have quite a lot of experience in at least meeting patients with FND or other types of somatizing disorders. But what you're really trying to get at when you're doing the assessment is what the underlying maybe mental health symptoms are or neurodevelopmental symptoms are, and then treating those or diagnosing those appropriately and making sure the right interventions are made in a young person's life. If it's, for example, that they have a comorbid diagnosis of ASD that they've not been diagnosed with yet. If it's comorbid depression or anxiety, and it often is anxiety, then certainly yes, if the symptoms are having a severe impact on the young person's life, we would consider fluoxetine. Are there any other?
Kirsten, there's a Mayuri's handed up, but I think it might be from before. If you can put it down, Mayuri, if it is, but I'll allow you to talk if you want to come in.
No, I think that was from before. Sorry about that.
No. So thanks so much for the points that people made, and Kirsten for your talk. I think we have to move on to give Kate time to do her presentation now. So Kate, if you're there. Thanks so much, Kirsten. So Kate is the ADHD consultant who's going to talk about ADHD prescribing and the melatonin guidelines as well. Thanks.
Yeah, thanks, James. So I'll just get my slides up and then get going. Oh, sorry. It says my screen sharing is paused. hold on, let me stop and try again. Apologies. We should all be really good at this by now, shouldn't we? Okay, apologies about that, but I think now it should be working. Okay. So yeah, I'm Kate Manning. I'm the consultant in the ADHD pathway at Hackney CAMHS. So a bit like Kirsten, in a moment, I'll just give you a bit of space for if there are any specific things you want me to cover today, so I can make kind of good use of the time with you. I've put quite a lot in the slides because I think they're going to be shared with you later, with a view that if we don't cover everything in a lot of detail, it's still a sort of a resource that you can look at. So I sort of tried to make them self-explanatory, even if we don't get to go over everything in detail. If, for instance, there's some things, you know, we decide we want to spend a bit more time thinking about. I'm going to really kind of briefly, just because I know this is a pharmacology session, but just kind of talk about the non-pharmacological treatment and then the medication, pros and cons, specific drugs, and finish with a few slides on melatonin. So I can see there's already some things in the chat. So maybe those are, no, those are different things. So are there any specific things, and I've just realized I don't know if I can see the Q&A thing anymore now, that you guys want me to
I'll try and keep you up to date if you want, Kate. Do you want me to sort of stop periodically?
Yeah,
or,
please do speak up if anything pops up. I mean, what I can do is I can work through the slides. If there's anything you want me to pause and spend a bit longer on, I can do that, because like I said, I kind of wanted to be a bit flexible about how I used the session, really. Great. So that it's helpful for you guys. Okay, so just a really brief overview. I won't spend too long about it, but this did come up in the earlier talk in terms of how many people are presenting with ADHD, maybe diagnosed outside of the NHS, because there are indeed, unfortunately, really long waiting times for assessments. So it's a really common disorder. The prevalence internationally is somewhere around 2 to 5%, and same in the UK. So we've got a population of about 250,000 people in Hackney, which means somewhere between 5 and 12,500 people in the borough probably have ADHD, probably. So, Jonathan, I wonder how a phenomenological diagnostic assessment sits with a neurodevelopmental disorder when there's no proof of underlying neurodevelopmental dysfunction. So I'm just wondering what you mean by no proof of underlying neurodevelopmental dysfunction. I'm happy for you to speak up.
Yeah, let me just give them the opportunity.
Yeah.
Sorry, I didn't mean to interrupt.
No, that's okay.
No, it's largely that at one end of the spectrum that we have very severely disabled adults and children, and then there's another end of the spectrum, which is the proliferation of privately diagnosed people with lesser symptoms. How given that all the assessment is phenomenological, it's descriptive. And there's no proof of underlying neurodevelopmental problems, then isn't that a problem? You rely on the history to prove that it was neurodevelopmental. You just say that it started early on, but how is that proof?
Yeah, I think this is probably a really big philosophical question.
Sorry.
But what we do actually know is that it's true of not just within psychiatry, but psychiatry particularly falls into this category of sort of the history being at the core of making diagnosis. But I'm sure within general practice, you also have to make diagnoses without knowing for sure that if you did do, a pathological specimen of what you're looking at, it is what you think you're looking at. So we don't always within medicine have absolute certainty. History is often what we're going on. But what we do know is that these are robust criteria that when you use these criteria to stratify people into groups, and obviously there's pros and cons to putting people into groups, but some of the pros are around making sense for them of what's going on, and also giving a sense of prognosis and what, you know, the risks and associated problems are with that. When you do look at people in those sort of categories that meet the criteria, phenomenological criteria of the diagnosis of ADHD, they are at higher risk of objective negative outcomes, including, well, I mean, I'm going to go into it a bit more later, but so there is validation of it as a concept of something useful. We're capturing something that is meaningful in some sense, even though I agree that philosophically, do we know exactly what we're capturing? Do we know it's exactly one specific thing? I'd say not. I'd say it's probably an umbrella term for a broad range of deficits within our kind of neurocognitive functioning. But what we do try and do in as robust a way as we possibly can, I suppose, is capture that this is something that's been present for a long time. And if we are sort of using the diagnostic criteria appropriately, then the evidence would suggest that we are intervening where there is benefit, and it's not just about kind of people feeling a bit better on it, but there are real and objective negative outcomes to missing and not treating ADHD. And I will go into those a bit more, but I appreciate I can't fully answer that in every sense. But, I mean, that's my take on it, and I think philosophically not everyone would be in the same place as me, but I guess this is what I do every day, so I have to believe it's meaningful. Yeah, so to answer maybe a little bit what is ADHD, I think I would, it's not a qualitatively different brain, an ADHD brain. We know that, as Jonathan was saying, you know, we're all on a spectrum of somewhere from the most disabled person with the most sort of severe ADHD type symptoms to someone with you know, perfect functioning. But what we can see from sort of the research looking at the sort of the physical correlates of the symptoms are that there are some quantitatively different aspects that can be picked up. So neuroanatomically, that certain brain structures are slightly different sizes, like the cerebellum, corpus callosum, parts of the prefrontal cortex, and altered cortical folding. And I would imagine that that's in the kind of more severe cases. But I would imagine in all cases, there'd be some abnormalities in brain chemistry. So dopamine regulation particularly is abnormal in ADHD. So that's associated with reward, motivation, salience, and learning, so that makes sense. And also serotonin and noradrenaline are also found to be, again, it's a qualitative difference, as I say. Sorry, it's a quantitative difference. It's not that there's an absolute black and white difference. These are all shades of grey, which is what makes it tricky. And differences in brain function, so problems with the pathways involved in executive functioning, motivation, reward, and attention. There's a big genetic component, so there's about 74% heritability, and that's not sort of one or two genes, but probably what seems to be the case is about kind of hundreds of thousands of genes seem to increase your risk microscopically more. And if you have enough of those, if you accumulate enough of those genetic sort of risks, you will be at more chance of displaying the phenotype that we describe as ADHD. So like I said, it's probably a bit of an umbrella term for a cluster of neurobiological entities that cause these downstream problems. So these are diagnostic criteria in DSM-5. I won't spend too long on them because they're not too complicated really, but for both inattention and hyperactivity and impulsivity, if you're 16 and under, you have to have 6 or more symptoms. For 17 and over, it's 5 or more symptoms. For at least 6 months, inappropriate for the developmental level, and also in the hyperactive and impulsive category, they have to also be disruptive. Several symptoms have to be present before the age of 12, several in 2 or more settings. They have to interfere with functioning, and as you'd expect, quite reasonably, not better explained by another disorder. So we see combined inattentive and hyperactive impulsive ADHD, or predominantly inattentive or predominantly hyperactive impulsive. So the first line option for mild to moderate ADHD in children, well, in fact, for all ADHD in children, is non-pharmacological management. This is first line for everyone. And it starts off at a really simple level with psychoeducation for parents, school, and the young person, and that may be enough. I've put on here just some websites, you know, in case you do have parents or young people or adults coming to you wanting a bit of information about this. These are some reasonable websites with sort of reliable information. And this is a young person, Jessica McCabe, who talks about her own experience as a person with ADHD on YouTube. We offer to everyone that is diagnosed with ADHD within our service, and also if they come into the service and they haven't had psychoeducation from elsewhere, we offer a parent information group that covers the diagnosis and treatment options, understanding the behaviours associated with ADHD, social learning theory, behavioural management strategies for reducing stress, and medication. So that's the core of what most people may just need, that, and then they may not need anything more. I've also just put this in here because I wondered if it was the kind of thing that might come up in primary care around diet, because this is the kind of question that parents sometimes will ask me, if they should be doing something from a dietary point of view. And NICE is pretty clear that essentially what we would say to any patient, which is a good balanced diet, good nutrition, regular exercise is essentially what we'd say. NICE doesn't advise eliminating any sort of artificial colouring or additives, or supplementing with things like fatty acids, and that there's really no evidence for the long-term effectiveness of any of these treatments. So I just thought that's the kind of question that might come your way. So then just thinking about why treat, and I suppose in relation to this, as with most things where you're doing a treatment, is what would it mean if you didn't treat? What would happen if you don't do this intervention? Because obviously when we're doing something, we're at risk of doing harm. So what if we don't do that? So these are the risks associated with untreated ADHD. Low academic attainment and fewer years in education. Substance misuse is a really big problem. So there's two sort of components to this usually. Either there's a sensation seeking element. So because their dopamine regulation isn't normal, it's really a lot more difficult for them to get a sense of sort of the kind of big pleasure, sort of enjoyment feelings that we might get from normal day-to-day life experiences. I can see there's a question about questionnaires. I might come back to that if that's all right. Sorry, I shouldn't have interrupted my own train of thought. But yeah, so they're at higher risk of needing like a really big adrenaline hit, or a really big hit from some kind of very pleasurable drugs. Essentially, that's kind of the brain needs a much bigger hit to get that feeling of enjoyment. So drug use is quite high from that point of view, but also we see a lot of self-medication, particularly cannabis for sleep. That's just a really common thing in young adults and adolescents with ADHD. They're at higher risk of sort of gang involvement and criminal behavior, particularly for girls, risky sexual behavior. So there's higher rates of earlier sexual experiences, more partners, unsafe sex, sexual exploitation, and unplanned pregnancy. There's high rates of road traffic accidents in people with untreated ADHD, and evidence that when you treat, that the rate comes back down to normal for the general population. Frequent job changes, underachievement, and unemployment. Again, this is for women. There's twice the rates of marital separation and divorce, and 6 times the risk of being on the receiving end of intimate partner violence. High rates of self-harm and attempted suicide, and risk of misdiagnosis. So particularly, say, a primary substance misuse problem, But also for things like, say, mood disorder, anxiety, or unstable personality disorder, as Kirsten was saying, sort of the first line for these, you might kind of suggest therapy. And if you've got someone with untreated ADHD who you're trying to ask them to organize themselves to get to a therapy session and then sit through it and give it attention, you're kind of in a way setting them up to fail. And I think that probably does happen quite a lot, unfortunately. So worth kind of thinking about whether it's present. So the treatment's effective. So the number needed to treat ADHD, number needed to treat for ADHD medications is 1.1 to 2.5, which compares with a number needed to treat of 30 for amoxicillin for lower respiratory tract infections, or ramipril as a number needed to treat 67 for preventing stroke over 4.5 years of use. So they're good, they're effective treatments. So Jonathan, ADHD really commonly accompanies autism. The two are really very strongly comorbid, and more we're moving towards the genetic and underlying kind of neurobiological differences are not particularly present. So it looks like they're not, it's very hard to distinguish between them, except maybe there's some genetic differences and the phenomenological presentation, what we see in clinic. So in some ways, they're probably part of that same, they're all probably on the same kind of spectrum. And so they're very often together. And sometimes it's about seeing what problems does this child have and present with and what needs treating and addressing. Complex PTSD is also really often comorbid with ADHD, but that's a more complicated question and we probably don't have time to get into that stage because I'm 18 minutes in already. So the other thing is the treatment is safe. And I will go into this a little bit more, but just a nice summary from NICE. Oh, a nice summary from NICE. But no evidence was identified for all-cause mortality, suicide, suicidal ideation, cardiac mortality, substance misuse, seizures, liver damage, etc. You will know successful follow-up of up to 12 weeks. And this is one of the issues around long-term both benefits and risks for ADHD medication. So I'm going to describe some other studies looking at some of the cardiac risks in particular that looked over a longer period of time, because I don't think 12 weeks is incredibly impressive. So risks and downsides. So there's always side effects and there's always risks, and we'll go into that a bit more later. And they are nearly always going to be worse for children with intellectual disabilities or autism. There's a risk that there might be unrealistic expectations about what medication can achieve. So it's not going to change or create motivation in a child who isn't motivated to work. So it'll be really helpful for those children who are trying to sit down and work and are just completely distracted, constantly procrastinating, but want to work. But it's not going to create the desire to work in someone that is not interested in academic work. And it also won't treat comorbid symptoms. So sometimes parents come and say, well, you know, the child is still really rigid, still won't do what I'm telling them to do because they want to do it in their particular way, and maybe doesn't recognize that symptoms of autism versus ADHD, understandably, because that's a difficult thing to disentangle. Equally, if the child doesn't want medication, this is not a daily battle that you want to give parents. So, you know, this is not something that is ever a situation where I'd say, you know, force, just, I mean, I think that goes without saying, but we do often get parents who kind of want us to solve what's wrong with their child, but that's not going to, this is not going to be the solution if the child is not on board. So guidelines for treating with medication. So we offer it to children 5 and over. I mean, actually, we generally do it for children 6 years and over, but it has to be if their symptoms are causing a persistent, significant impairment after environmental modifications have been implemented. So we tend to give a lot of advice to schools and parents about how they might support the child. What I will say is if we've got a child that's completely in crisis, maybe has been expelled or about to be expelled, or there's some major issues that are very clearly related to untreated ADHD, in that situation, I probably would treat rather than wait. So you have to have discussed information about ADHD with the parents and done a baseline physical assessment, which is taking a good history, plotting their height and weight on a growth chart, baseline heart rate and blood pressure, and then a cardiovascular assessment. So that's looking for personal history of cardiac problems, sudden cardiac or unexplained death in a first-degree relative under the age of 40. So this is really specific. That's NICE is very specific about that. And any personal cardiac symptoms in the child. And on examination, signs of heart failure, murmur, or hypertensive blood pressure, if it would be hypertensive for an adult. So for any of the above, NICE says it needs a cardiology referral prior to medication. I put that in brackets because I think, apart from the first bullet point, I think any of the above would probably need a cardiology referral, whether you think about medication or not. But yeah, so there was a time when NICE was suggesting ECGs routinely for everyone before starting methylphenidate, but that's actually not the case now. They've really made it much more about, do they need a cardiology referral, or if not, then it's pretty much safe to go ahead with the medication. So we use methylphenidate first line. I usually go for the long-acting one because no one wants to have to take 3 tablets in a day, let alone a child with ADHD. And if you think that it's genetic, they've also potentially got a parent or more than one parent with ADHD trying to organize it too. So Medicanet and Equisim offer 8 hours of symptom control and Concerta 12 hours. I usually start with the 8-hour ones because nearly everyone gets the side effect of appetite suppression when they're on a dose that's treating their symptoms of ADHD. So for a child, I'm trying to minimize the amount of time during their day that they've got some sort of appetite suppression. So 12 hours is quite a long period of time. I might use immediate release methylphenidate if it's a child who's been really sensitive to side effects previously. And so it's only 4 hours. It's less likely to give side effects in my experience. So it just seems to be a bit easier to manage. And also we use it as an adjunct if medications are wearing off towards the end of the day. Might be a bit better than the 12-hour option to give them a little adjunct kind of around lunchtime. Methylphenidate is really effective at treating ADHD, but it doesn't suit everyone because it's got side effects. Also, for reasons I can't explain, some people suit one formulation and not the other, and it's really hard to predict who's going to get on with which of those 3 longer acting options are available. It seems quite idiosyncratic. So there's a bit of trial and error in it, really. I tend to start at 10 milligrams, although 18 for Concerta is the starting dose. And then I titrate up fairly slowly. Usually for children, 20 to 40 milligrams is about enough, although the maximum licensed dose is 60 and unlicensed we can go up to 90, but I've got no one on anything close to 60 milligrams in my caseload at the moment. And I go quite slowly because I'm trying to identify the minimum effective dose. So in theory, you can increase by 10 milligrams every week, but from my point of view, I tend to do it monthly actually, because there's usually no rush and you want to work out what's the smallest dose that they can stay well on. Okay, oh, I'm so sorry, there's only 5 minutes left. I'll go, I might just whiz through some of these bits. So these second line options, you probably don't need to know too much detail about them except maybe the names of them. So we use Elvans and then dexamphetamine is a shorter acting version of Elvans second line, or atomoxetine, particularly if some of the stimulant type side effects on the appetite have been a bit of a problem. But with atomoxetine, they've got to be really good with their compliance. So I don't jump to it quickly. The other option in that context is guanfacine because it's sedating and reduces blood pressure and increases appetite. So I don't have very many young people on that, but it's an option for ones where the stimulant's really not suited them. So I might actually just skip through this really quickly because the shared care protocol has loads of information on adverse effects and side effects, but I've put in bold the ones that I see commonly. So the GI ones are really common. Reduced appetite is almost ubiquitous. Stomachache is really common, but tends to go away. Dry mouth. Insomnia is obviously common. From a cardiac point of view, although I've highlighted the palpitations, tachycardia, and increased BP, I don't see that lots, but I've just put it in there because they're quite important, and it's not a never event for us to see those things. And NICE has quite clear guidance about when you would need to worry about those. Thank you, Jonathan, for that link as well. Obviously, weight decrease is the other really important one, given the reduced appetite. So I might not go into these in great detail, but these are just 3 really big, helpful studies that looked at masses of data around young people using stimulants and the sort of risk of sudden cardiac death or cardiac events or cardiac symptoms, and essentially found, I mean, Winterstein's study there looked at 42,000 person years of current stimulant use and found no cardiac sudden deaths. Olsen at the beginning looked at 1 million days of current stimulant use, and the adjusted odds ratio of cardiac events was 0.69, so it was actually lower than people who were previous stimulant users or not using stimulants, never used stimulants. So this, I think, is just important because parents will often look online and be quite worried about cardiac risks with these medications. They also sometimes ask me about whether these drugs are addictive, because methylphenidate is like cocaine, a dopamine reuptake inhibitor, but taken orally, it takes an hour for the concentrations of the brain to peak, so it doesn't give you a high, basically. But if they crush it and then snort or inject it, there is a risk of them becoming addicted. So in theory, there is a risk, but in practice, taken appropriately, there's no risk of them becoming addicted. Needing it to function is not the same as being addicted, as I'd say to parents, and you can most definitely stop abruptly, because lots of my patients do with no withdrawal symptoms. I'm not saying it's good that they do, but a lot do. I'm not going to go into all of these side effects and the contraindications, because you can take those away. The monitoring guidelines, so height, weight, heart rate, and blood pressure, all to be done at baseline, and then 6 monthly once they're on treatment. And I do heart rate and blood pressure every month after I change a month after every dose change, and with weight, you need to do it at 3 months after dose changes when they're under 10. From the point of view of that, because I guess this might come your way, if they've got a sustained resting tachycardia of more than 120, an arrhythmia or systolic blood pressure greater than the 95th percentile on 2 occasions, then at that point, we'd need to refer them to pediatricians or an adult if they're over 16, and we'd be reducing, I'd probably be stopping their methylphenidate, to be honest, if that was going on, and thinking about something else for them. Okay, we're at time. So melatonin, I'm so sorry, I can do this in 1 minute. Use this for treating sleep onset insomnia and delayed sleep phase syndrome. It's really helpful for children with neurodevelopmental disorders because they often have difficulty sleeping, but it is an off-license use. We would use it if they've had sleep disturbance for at least 6 months, it's causing a significant problem, and they've put in place sleep hygiene, parents or the child, with no effect. There is a shared care protocol that gives the details about how you would prescribe it, but you start at 2 milligrams MR, and you can increase every 1 to 2 weeks. I usually do a bit slower than that, to a maximum of 10. I don't tend to go much higher than 6 usually, to be honest. Take about an hour before bedtime. They can take breaks from it, and that really helps reduce the risk of tolerance. And that's how you can manage to not need to just keep slowly increasing the dose over time. So they can halve the tablets, and it will still be modified release to some extent. If they can't swallow, then you can crush it, but it won't be modified release anymore. Really, it's very well tolerated. There's minimal adverse effects and risks. unfortunately, as with so many things, the long-term side effects haven't been evaluated. Nightmares is really the thing that people say to me. I've never really seen any of the other things that are mentioned on here, but I put them in for your information. It can be stopped just immediately with no problem. Discontinuation seems to be fine. Taken in overdose, there have been doses of up to 300 milligrams taken without any adverse reactions. Reported in the literature, drowsiness and reduced body temperature, you might see if they do that. It'll take about 12 hours to clear, and they don't need any special treatment if they do take an overdose. Contraindications are being sensitive to melatonin, hepatic impairment, or autoimmune diseases, or taking immunosuppressants. So I'm so sorry to have not really left any time for questions at the end here, but I am really happy to take questions by email. The shared care protocol and the NICE guidelines are really helpful resources for everything that I've covered today. But like I said, I'm really happy to have any emails if you have questions. Sorry for running over, James.
It's a shame that you had to rush because it was a really interesting presentation. Kate, thanks. I know some people might have to leave, but are you able to stick around for a couple of minutes if people are able to, or have you got to go? Don't worry.
Unfortunately, I'm speaking to a mum.
Yeah, no, absolutely.
I'm supposed to be speaking to her now, so yeah, I'm so sorry that we didn't have as much time as, but I am happy to take questions from people by email or.
Thanks very much. Yeah, it was really illuminating on a subject that is exploding, and yeah, I'm sure people have got lots of questions for you, so that would be great.
Yeah, thank you, everyone.
Thanks so much to all the attendees and all the panelists for your input today. See you all soon in person. Cheers.